and welcome to the Dr. Bob Show. We'll be spending most of this show talking about total knee replacement, about what's new and what's modern and what's in the future for knee replacements. A lot of information for you. Everybody, as we get older, seems to have bad knees. Is knee replacement in your future? Are robotics in your future? Assisted robotics, minimally invasive, the regular old-fashioned total knee replacement? We'll be talking about those and we'll see what's best for you. My guest is Dr. David Hovis. Dr. Hovis is a board-certified orthopedic surgeon, and he'll be answering our questions, and he knows the answers. Hello, I'm Dr. Robert Overholt. I'll be your host for the next 30 minutes on the Dr. Bob Show. Later on, we're going to be talking about what are the early symptoms of heart failure. Don't feel good, tired, short of breath a little bit? We'll be finding out if your symptoms could be heart failure rather than just fatigue. And nephrolithiasis, whoa, those are medical words for kidney stones. We'll be talking about kidney stones, two main types. Why do we get them? Who's at risk for them? And what can we do about it? A lot of information for you. You'll want to stay tuned. We're talking with Dr. David Hovis, board-certified orthopedic surgeon, and we're going to be talking about the advances of total knee replacement and what's new in the future. David, welcome to the Dr. Bob Show.
Thank you, Bob. I'm glad to be here.
So why do people end up needing knee replacement?
Well, as we age, one thing that happens is we get certain breakdown in some of our tissues, whether it's soft tissue or whether it's the articular cartilage. And a lot of patients, they've had old trauma, old injuries. They come in after years of non-operative type things, whether it's anti-inflammatories, and they have pretty notable arthritis in their knees.
Yeah, and people begin to limp and they begin to say, I think I'm getting ready for knee replacement. And usually the doctor says, you'll know when you're ready. What does that statement mean?
Well, it typically implies that our first course of action is non-operative care. We want to see how well these patients can do with some of the non-operative things before we start resorting to surgery. So we'll guide them in things like anti-inflammatories.
Like what? Anti-inflammatory?
Motrin, over-the-counter ibuprofen. So
ibuprofen type medications.
Exactly.
Physical therapy?
Physical therapy, absolutely.
Injections into the knee?
That's right.
What kind of injections?
Well, there's several that we use. The old standby is the cortisone shot or steroid injection, and we still use those quite extensively, but I do counsel patients that the reality is some of that medicine will degrade tissue over the course of time, so we don't really love to do lots of those. There's other injections like viscosupplementation. It's a lubricant for the inside of the knee that actually is not a drug. FDA calls it a device. It lubricates the joint, calms down pain, calms down some of the inflammation. Hyaluronic
acid.
Yes, sir, that's right.
We call it WD-40.
Exactly.
And it does a good job on some people.
It does.
And then when all of that finally doesn't work, then you make the decision on knee replacement?
Often we do. So if somebody's a candidate for that, if they've gone through the non-operative course and they're still having trouble, they're still having pain, and their medical problems don't prohibit them from surgery, things like that, then we will start talking about total knee replacement and what that would look like for them.
Back in the old days, how did total knee replacement start? What did you do with that? Let's start from the beginning. Let's walk up to current.
Okay, so kind of historically, we used to make a pretty broad incision on the knee, and that was so the surgeon could see everything very well and make sure that he was right where he wanted to be and doing the operation as best he could. We would cut through some of the tendons and move those out of the way with the intention of sewing those back up later on, but it allowed a very nice exposure. And then we used cutting blocks, literally metal cutting blocks, that would guide the cuts that we actually make on the bone so that the implants would fit right.
You know, when you would tell people what you were doing at that time, it really sounded rather archaic. They would saw off part of the end of
Saws
the
and
knee.
hammers.
Yeah, 5-pound hammers, and that, you know, it made people say, "Oh, on my knee they're doing that."
Right.
So then it walked into more minimally invasive. What does that mean?
So minimally invasive implies that we're trying to cut through less good tissue. We're trying to move that tissue out of the way so that once the surgery's done, that tissue is healthy and it rebounds and functions well. So if we can move it out of the way instead of cutting through it, make a smaller incision.
Yeah, and so that would mean the patient gets back to work quicker and doesn't have as much post-operative time.
Exactly.
So let's walk into what's next.
Okay, so new things that we've implemented are new ways to control pain at the time of surgery, certain injections around the knee that have given patients 24, 36 hours of excellent pain relief afterwards, so that after surgery they can go home same day in many cases. They can walk on it, put all their weight on it, and not really have any pain the first day or so. Now these are all hopeful things. Not every single patient has, you know, no pain with it, but their pain is vastly better, and it allows a really good start to their rehab program.
So what do you put in the knee to make it where it doesn't hurt so they can go home quicker, so we can get out of the hospital and they get back being active?
Absolutely. So one of the chief medicines is bupivacaine. It's one of the pain blockers that we can inject, an injectable medicine that will block that pain, numb it up, if you will, so that patients aren't feeling it. Other medicines that we'll use along with that, we can use an anti-inflammatory called Toradol, and that will also help dramatically. And then we'll even put in a little bit of epinephrine in there, which the purpose of that is to keep it there, keep it all right there close by, so it keeps working.
So that's really been huge benefit to the patients who weren't suffering as much for 2 to 3 days, and allow them to get back home quickly.
Exactly.
So let's go to robotic surgery. Is it done by robots?
Well, it's done with the use of robots.
With the use of robots. So we now call it robot-assisted surgery?
I think that's accurate. That's right.
Okay, and Makoplasty, and I'm using those words because that's what I want you to teach me about. I just learned how to pronounce the words. Tell me about Makoplasty, robot-assisted surgery.
Yeah, absolutely. So Makoplasty is one company's robotic-assisted surgery for total joint replacements. And it happens to be one of the leaders with the robotics. It first came to market about 2006. And
so it's been there a long time.
Well, it's been around a long time, but it really hasn't gotten adopted in widespread use for quite some time. And so what that allows us to do is to plan the patient's surgery completely beforehand. We get a CAT scan before the surgery.
Now, what's a CAT scan? What is it? This is a special CAT scan.
It's a special CAT scan of, let's say, the knee, in this case, the knee.
3D? 3D-dimensional?
That's exactly right. 3D CAT scan that we can see on the computer, and then put the implants on the computer as precisely as they can go. So we're doing the operation on the computer first. Then once that information is locked into the system, we're happy with those we know that we have the sizes the best, that information will go into the actual robotic system, the robotic arm, and at the time of surgery, I'm using a robotic arm, and I'm actually doing the cuts myself, but the robot guides so that we don't stray away from that exact plan that we want to execute.
So I think what I'm hearing is everybody's knee is different.
Absolutely.
Every problem in every knee is different.
Right.
And so one side may be different on one person and the other side on the other. And so the robotic information that they're getting comes from the CT scan, tells the artificial intelligence what to do? Is that what it is?
Well, so from the CT scan, then we can design what the actual operation should look like for the patient, putting those implants right where they go. And then at the time of surgery, I tweak that a little bit as we look at the ligaments, we balance the ligaments. I can move the implant subtly so that the patient gets the best motion, and we just have the best fit for that knee.
Was this hard to learn?
You know, there were a lot of nuances to learn with it. Many steps about it are similar to the way that we've always traditionally done it, but what it's really allowed us to do is make smaller incisions, cut less tissue, less bone, and really do what I am quite confident in is a better final product for the patient.
Patient recover quicker?
You know, given all of the things that we're doing, I mean, they're clearly recovering more quickly with the robotic piece. The chief piece to that is the accuracy. And if we can get that as accurate as it can be, then they're recovering at the same rate or faster just because those implants are right where they want to be.
Is it pretty accurate?
It is very accurate.
And that's what we're going to be talking about. The accuracy is what makes the Makoplasty different and makes the knee replacement more advanced. Stay tuned. We're going to find out what Makoplasty and what using the assisted arm of the robot, how that's really done. You'll want to stay tuned. We're talking with Dr. David Hovis, board certified orthopedic surgeon. We've been talking about total knee replacement. Eventually the knee wears out. Replacement is in store. We started with the old-fashioned kind, which is still sometimes done, very effective, do a good job. But as we have improved, it's been more minimally invasive, where smaller cuts are made and where we don't expose so much soft tissue so we can recover quicker. And then we got into robotic assisted knee replacement. The key, I think, is a CT scan, which is three-dimensional, which walks through the whole knee and can then tell the robot what he needs to be doing, and it's implanted and makes it where you can't make a mistake, sort of. Is that right, David?
That's pretty right. That's right.
I'll let you correct that. And so I've been fascinated by your education in medicine. Can we walk through, where did you do your undergraduate work?
I was at Duke.
Duke University, and you were cum laude there, and from there you went to?
Vanderbilt.
Vanderbilt, and then from Vanderbilt you went to?
University of Texas.
University of
Southwestern.
Texas. Southwestern. And that was Parkland Hospital, and people don't realize what a great institution Parkland is. And so you were there doing?
Orthopedic surgery.
Orthopedic surgery. And while you were there, you got training overseas.
I did. So part of our training was in exactly total joint replacement. I did a semester over in England where many of the total hip replacements were created, designed from the very beginning when doctors were first starting to do that operation. So I got an amazing historical perspective on doing total hips there, was able to learn about their medical system, and then also spent an extended period of time in Switzerland doing the same thing with total shoulder surgery. So.
And then you went up to with a Dr. Stedman up in Vail, Colorado, one of the leading orthopedic surgeons in the world also.
Yes.
So what did you do with him? And then you became involved with the Denver Broncos.
That's right.
So tell me about Stedman and the Broncos.
So out there, my training was in sports medicine, which really involved a lot of knee and shoulder surgery. So we were taking care of athletes from really all different venues and all places around the world. People would fly in from various places, and it was very exciting. It was an exciting time to be there, and we got to take care of the Denver Broncos and be on the sidelines for one of their Super Bowl wins back in the 90s, and it was really fun. So.
I should have gone into orthopedics. So let's get back to robotic surgery. Let's do Makoplasty. Walk me through a patient getting ready to go in the operating room and what you do in there again. And let's talk about haptics.
Yep.
Is a word that I halfway learned. You'll teach me about that.
So as we're preparing for this robotic surgery, patient comes into the operating room and we have them with anesthesia. That means putting their leg to sleep so they're feeling nothing. Typically we can do it without putting any tube down the throat, and so the patient's not technically totally awake. They don't really remember or hear what's going on, but they're in a comfortable comfortable state of a little twilight sleep, and then we've got a numbing shot that puts their leg to sleep. At that time, once we have everything all prepped and all the gowns on and all the drapes on, one of the first things we do is we put some optical sensors on the leg, which really amount to a couple of pins in the bone, both above and below the knee, and then that allows the robot to see exactly where the knee is at any time. So I can move the knee in any direction, and the robot, the arm, as far as how I'm using it, it'll move with the knee, and it knows just exactly where we are in space, which is really fun.
You've pre-designed what you're going to do for that one person's knee, and the robot has all the information and lets you do what?
It lets me to make a smaller incision, move the muscles out of the way, and then we can make a cut without any other device like a cutting block or anything like that, and it just lets us make a perfect cut on the bone where we're taking away just the amount of bone that has to move for us to do the operation.
I was looking at a video of this, and it makes it where it just doesn't allow you to get out of the site where you want to be, and it tells you how much cartilage or bone or replacement to take out and to put back in.
Exactly.
So you do use a saw sometimes in there with the robot?
That's right. So we still have to remove that bone, and so the robot does. We can change it from a saw to a drill to a burr, and there's different applications that we might need each one of those things. But for a total knee, for instance, a large part of it is a saw, and we still use a saw. It's a very fine-tuned, very precise instrument, but it cuts away the bone just as we want it to.
And the replacement that you put in, what's that made of?
So there's a few different materials. One is cobalt chrome, and that's used because it is such a nice low coefficient of friction. Things slide very smoothly along that surface.
That's what you want that knee joint to do.
Exactly. One of the components down on the bottom part is made out of titanium, and that's utilized because it's we call it the modulus of elasticity. It's so close to bone, it behaves very much like that, and then bone can grow into that substance too. And one of the great things we're doing is we're eliminating cement as one of the necessaries for surgery, and bone can grow into that implant without cement, and that's a really strong fixation.
That's fascinating. Do you think they'll be able to put stem cells in there in the future to even reduplicate better what the tissue is supposed to be in there?
Well, we're already having trials of that, and so using some bone marrow stem cells to lace around that and try to improve the healing there, absolutely.
So you've got titanium, and then you've got the upper part was
cobalt chrome.
Cobalt chrome.
And then in between there's a plastic. It's called ultra high molecular weight polyethylene, and it essentially amounts to a very high grade medical plastic that allows these components to glide very smoothly.
So sometimes it looks to me like when you get the knee replacement, it's better than the old one.
Well, it's better than what they were trading in for anyway. So.
Oh, that's right. I've actually had both of my knees done, and they're my best joints. And I think that's what people say. I wish I would have done it sooner. But now what you're telling me is we're able to do it with more accuracy and with less invasion of the tissue, and the patient does better. When the patient goes home, what do you have them do?
So first off, we want to manage the soft tissue and the wound, and typically there's very little wound management anymore. We don't have to do a lot of dressing changes. We go to great lengths to make sure there's minimal bleeding. Now occasionally a patient does still bleed some, but we try to make sure there's minimal bleeding. They have a dressing on that is waterproof, and that one waterproof dressing can last for 2 weeks. They can shower with it on. We want them to be active. We want them to be up with their walker. We want them to start walking and putting their weight on it. And then we get them into physical therapy. And that's a huge part of the whole procedure. They need to do their therapy. They've got to work on their motion and their strength.
There's no free lunch, is it?
That's
You've got to really work. And the harder you work, the better job you do, or the better job you do of following what the physician says, then the better the results are going to be. A story of a patient that had the surgery and how quickly he got back to work.
That's right. So, you know, I'll tell you the typical patient, and this is what I tell my patients. I expect that you're going to have surgery tomorrow. You're going to have an operation that lasts about an hour and a half. You'll be in recovery for about 2 hours, 3 hours afterwards, as we're making sure that you're doing well, you're feeling good. We do your initial physical therapy and get you up walking, and then you'd be able to go home same day in most circumstances. Sometimes spend one night in the hospital, but able to go home same day. When you get home, I want you to prop this thing up. I want you to put ice on it. I want you to take the medicines as we tell you to take it, and I want you to just not worry about things. And we're going to get this going, and we're going to have your physical therapy start this week, and patients respond well to that and typically do very well.
David Hovis, you're a wonderful, wonderful teacher. Thank you so much for coming to the Dr. Bob Show and tell us about how knee replacement is advancing into a robotic age.
Thank you.
A lot of great information. Boy, did I learn a lot. Now you're going to want to stay tuned. We'll talk about early signs of heart failure. It's more common than you think. And if you're not feeling good, it could be due to heart failure. And kidney stones, what kind cause problems and what are the symptoms? A lot of information for you. You want to stay tuned. I want to thank Dr. David Hovis. Wonderful discussion on robot-assisted knee replacement and how knee replacement has advanced and what's in store in the future. Thanks, Dr. Hovis. Now, questions from you, the viewer, that I think will be important to your health. First question, Dr. Bob, what are early signs of heart failure? Well, the heart is the most important muscle, I guess, that we have in the body. It beats automatically. It's an automatic vagus nerve that makes the heart beat 60 to 100 times a minute would be normal. Men usually have a slower heart rate than women. Women's normal rate would be 72 to 75 and men would be 65 to 70. And the heart beats efficiently. It's a great muscle. There's two big pumps, the left pump, the left ventricle, and the right pump, the right ventricle. Both of those are muscles that are nourished by the coronary artery. If something happens to the coronary artery, then we can have the heart muscle not performing as well. So coronary artery disease sometimes will accompany heart failure. Now, heart failure doesn't mean the heart stops. It means it's not beating efficiently. If the left side does not beat efficiently, then it doesn't give the body enough nourishment. So it supplies the fingers and the toes and all the rest of the body. If it's not doing a good job, we call it the ejection fraction, which is about 60 to 100 cc's would be normal. Not very much blood, but it's beating out every beat and supplies the rest of the body. If that left ventricle doesn't do a good job, then it's receiving blood from the lungs, and therefore the blood will back up into the lungs. It can't get to the heart because it's not beating it out good enough. That's heart failure. When that happens, you get tired, fatigued, your feet swell, you get short of breath. You get short of breath at nighttime. When you're active, you get short of breath and sometimes chest pain, sometimes irregular heartbeat, sometimes your diabetes is out of control. So lots of things can cause that heart failure. The right pump gets blood from the body, sends blood up to the lungs. And so if it's not working well, then the blood backs up to the rest of the body, to the toes and to the belly. And so we can get a swollen belly and swollen legs. You'll recognize it because you don't feel good and you're short of breath and you won't be eating well and you won't be nourished. So if you're not feeling good, talk it over with your doctor. He'll be able to go over signs of heart failure with you. Question number 2, Dr. Bob. Tell me about kidney stones. Well, the kidney is in the back. It's not in the abdomen. It's behind the belly. And it's right in the back. So sometimes people, if they've got back pain, they say, I wonder if it's my kidney. Well, it's on the side. And if the kidney is infected, there's a lot of pain if you hit the back. The kidney has to take the blood that's coming to the kidney and it has to filter it out. And two of the things that are filtered out are calcium and uric acid. And the calcium and uric acid in some people are elevated so high that they will begin to crystallize in the kidney. We call that nephrolithiasis. And frequently, that's a big kidney stone. But part of that can break out and get into the ureter. And so the symptoms we have is back pain and pain that comes around the front in the groin area to the bladder. It's a pain where people just can't get comfortable. And it's a severe pain, one of the most severe pains that we can have. If you've got pain like that, know that your doctor will be able to diagnose that. And the treatment is very, very effective once they find out if it's uric acid or if it's calcium. All the time that we have for this show, remember those 4 things that we like to do. Number 1, it's exercise. When you exercise, it'll cut down on stress, it'll make you feel better, you'll have a runner's high, you'll look forward to the exercise, it'll keep you healthy, it'll keep your heart healthy. It actually gets new blood vessels going to the heart when you exercise. And you can start doing that at any age. So it doesn't have to be that you're running, it can be walking, probably the best exercise you can do. Be sure you get 7.5 hours sleep. That's enough sleep where the body can reestablish and re-nourish the brain cells. So you need to know how to sleep. If you're not sleeping well, you need to talk with your doctor. There's so many causes of inadequate sleep. Proper nutrition, what you eat is what you are. So eat less, eat better foods, cut down on the fried, fatty foods. And most of all, what is it we like in the Dr. Bob Show? Is that laughter in your life. Remember how important laughter is. It does keep you healthy. It makes the immune system work better. People around you will be happier. You'll perform better. And the more you laugh and the more you giggle, the healthier that you will be.